want to first and foremost start by thanking the CPAN committee, education committee, and the CPAN entirely for giving me this kind of opportunity to make such a presentation. I'm glad that we're all pharmacists, so it's not going to be a kind of presentation that will be so much academic. I look at this kind of presentation as a kind of platform provided by CPAN for pharmacists, or specifically clinical pharmacists, to come together and interact in order to find, to project the name of pharmacy together. And it will be a kind of platform where we all come together to learn from one another. So the fact that I'm standing here to make a presentation does not mean I own the whole thing. It is expected that at the end of the whole thing, we will hear different views, different versions, and different, in fact, we hear a lot of criticisms, a lot of suggestions, a lot of moderations, such that at the end of it all, we are all going to put our heads together to make sure that we learn one or two things. To start with, the impacts of patient education in optimizing the benefit of drug treatment in the management of asthmatic patients is the topic for today. Why I've chosen this topic is for the fact that I've closely monitored most of the presentations and other in different fora and even in CPAN. Majority of the presentations have been coming on cardiology, endocrinology, and a lot of other areas. And nobody has touched the areas of pulmonology. That is the reason for the choice of this particular topic. And I decided to coin it the way I've coined it because I realized that one of the missing link we have in the practice of clinical pharmacy is the fact that we always talk about majority of how to go about drug therapy problems, improving quality of life, doing blah, blah things without bringing the patient into the center of the whole thing. Last week, we had a very nice presentation where Dr. Pounds tried to give us an insight of consultants, pharmacists, and specialist pharmacists as it relates to the United States of America. And I think the key thing about her presentation was that collaboration was emphasized. That collaboration between pharmacists and other members of the healthcare team. What I want to add here is that I want to add to what she had said by way of emphasizing on the collaboration. But to make it much more clear, we must understand that collaboration, especially in the management of chronic disease conditions such as asthma, patient is the most important in making such collaboration. Because when we collaborate only amongst ourselves as healthcare professionals, and we leave the patient outside the collaboration, then automatically at the end of the day, the results of the management may not be that optimum. So we must understand that in most of the chronic disease conditions, patient is at the center of that collaboration. And whatever collaborations we are going to make, we must make the patients the priority of that collaboration. What I've been talking about here is that from the beginning, the patient gets into the hospital and to the point when the patient is diagnosed of having any disease condition, especially when it is a chronic one, the patient is supposed to be brought in. So what I'm trying to say here is that my presentation might probably look like the normal presentation where we talk about the disease condition, diagnosis, symptoms, and of course, every other component, trying to emphasize the role of clinical pharmacists. But from my introduction, what I want us all to understand is that when you talk about collaboration, it means the management of that patient that has been diagnosed with asthma lies on all of us, including the patient. It means everybody's role is almost equal to every other person's role. And choosing a particular role to play only on my own side might not benefit the patient. specifically, especially if I do not understand, if I do not choose the right, if the choice is misplaced. That's what I mean. So when a patient is at the center and the patient has been diagnosed with a chronic disease condition, from the beginning of the diagnosis to the point when the patient is going to be placed on drugs, the patient must understand why and how the diagnosis was made and what is the implication of that diagnosis, such that when the drugs are prescribed, where the pharmacists play the most important role, we now begin to see how we are going to strategize to make the patient benefit maximally from the impact or from the effects of the drugs by way of maximizing the efficacy of the drugs and minimizing the side effects of the drugs. I use the two words, maximizing the benefits and minimizing the impact. Let me not waste our time here. Go straight to the definition, as rightly as you can all see on our screen. Definitions here, I am not talking about definition of formal definition of asthma. Rather, I try to describe asthma in this particular slide. Most of what I have explained in our subsequent, right from the very first statement where you can see chronic inflammatory disorder. Of course, we know it is a chronic disease condition because it's a long-term, it is a long-term disease condition. And when you say it is a chronic inflammatory disorder of the airways, we know the airways are the lungs. The major manifestations, when you talk about the symptoms of these disease conditions, are wheezing, coughing, chest tightness, difficulty breathing, and breathlessness. And of course, all these kind of symptoms I have mentioned right here are caused by two important things, one of which is the bronchial hypersensitivity to stimuli, and at the same time, airflow obstruction. So by saying chronic inflammatory disorder, what we are talking about here is that we know how the lungs look like anatomically. I'm not going into the anatomy of the lungs, but we know when asthma is set in to an individual, we are talking about certain changes that happen within the lungs. And those changes include a series of events. Those changes include series of events that come together to block the airways. And those changes are inflammation, you have edema, you have hypersecretion of mucus, you have bronchoconstriction. By the time you have all these coming in together, the airways through which oxygen air, let's say air passes into the lungs, will get blocked. And by the time they get blocked, we can see there's symptoms of asthma. And these symptoms will now begin to come up. The wheezing, the coughing, the chest tightness, the difficulty breathing, or the breathlessness, and the rest of them. So the next slide. So when you look at all this, you can understand that saying asthma is a chronic condition, it means it takes a long time to develop. Looking at the various symptoms of asthma, which is the coughing, the wheezing, and the rest of them. And of course, talking about those changes in the airways, in the lungs that are responsible for those symptoms, which I mentioned as the inflammation, edema, hypersecretion, that means excessive secretion of mucus, and other things that come together. This is just trying to briefly explain the pathophysiology of asthma. And from here, we can directly link it to the drug treatment, because when all these things are happening, if we remember the drugs that are used for the management of asthma, those drugs act either independently or together to reverse some of these changes that have happened within the lungs. Some of the drugs are anti-inflammatory drugs. Some of the drugs are bronchodilators. Some of the drugs are immunomodulators. Some of the drugs tend to depress certain mediators, which we call mediators, autocoids, histamines, and the rest of them, in order to prevent the process of inflammation, because one of the things that happen to block the airway is inflammation. So all those drugs that come together to work either independently or together, they work in trying to open the airways, because in asthma patients, the airways are blocked by those reasons based on the changes that happen. And of course, by the time we have this type of understanding, we move to the next slide where we classify the asthma into like 4 different categories according to classification or according to the standard guideline. You can see we have different classification, and those classifications are either intermittent and mild persistent, moderate persistent, or severe persistent. This type of classification is based on appearance of symptoms, meaning in intermittent classification is talking about less appearance of symptoms. In most cases, the symptoms hardly appear in a week more than once or less than 2 times. By the time you move to intermittent to mild persistent, that means there is an increase in the appearance of symptoms. We know how symptoms of asthma is. They tend to depress the patient. They tend to stop the patient from going about his own normal activities. They tend to stop the patient from involving in many other things. And as you move from intermittent to severe persistent, you get to a point where the patient might move from having less than 1 symptom in a week or less than 1 attack in a week to continuous attack. Because when you get to moderate persistent, you might have a situation where the patient will be having daily attacks. By the time you get to severe persistent, then automatically the patient gets to a level where the patient will continue to have continuous attack, non-stop, only probably once in a while. But persistent, severe persistent is the step 4 of the classification of severity of asthma. So what we are saying here is that anytime you have to institute treatment, you have to look at the classification of that asthma and understand the state at which the patient is for you to recommend appropriate medication. Because when you give medication for intermittent asthma to a mild persistent asthma, it might not work. The same way when you move it to the moderate persistent and severe persistent. Next slide. Next slide. So I have already explained part of the pathophysiology, and this one is just to buttress the points I've mentioned earlier. When you look at bronchoconstriction, you talk about airway edema, you talk about airway hyperresponsiveness, you talk about airway remodeling. This set of pathophysiologies are caused as a result of activation of what we call so many precipitating factors. We call them cellular elements: the mast cells, the macrophages, the neutrophils, and the eosinophils. And of course, they are responsible for triggering the release of mediators, which I told you earlier as the histamine, leukotrienes, prostaglandins, interleukins, and the rest of them. These mediators will now act on the lungs to begin to cause the inflammation, increase vascular permeability, and of course, mucus hypersecretion. And of course, by the time there is no proper management, by the time there is no proper control of symptoms, when you look at the pathophysiology at the bottom of the 3rd box, you realize that there is what we call airway injury and epithelial damage. So that is what we call airway remodeling. We have when there is no proper management in patients that are said to have asthmatic attack, then there is likelihood of getting to the level where there will be injury and there will be epithelial damage. And in that case, this kind of asthma used to be very difficult to control, no matter the medication. Next slide. So this is just to show you a little bit of what I've explained in terms of blockage of the airway. When you look at the diagram B and diagram C, you will see how the airway is open, which is a normal airway. But by the time there is those changes in asthmatic patient, you can see how the airways are blocked. Next slide. So just like I also explained in my first slide, I told you what I presented in my first slide is just a combination of everything. Here is just to remind ourselves about the symptoms. And of course, these symptoms of cough, wheezing, chest tightness, difficulty breathing, and what have you, they are particularly if these symptoms are frequent and recurrent. That means you can only say to they can only said to be symptoms of asthma when they are particularly frequent and recurrent, and they are usually worse at night and in early morning, or they are in response to or worse after exercise or other triggers, such as exposure to pets, cold, damp air, or with emotions such as laughter. Next slide. Next slide. So when you look at diagnosis of asthma, why I am coming through this is for us to remember, just like I explained in the early in my introduction, the patient has to be together. You have to take the patient together in doing all this. Because the first thing to do when a patient presents himself to the hospital is going for uh, the patient, when patient presents himself to the hospital, the first thing to do is to start evaluating the patient. And during the process of evaluating the patient must be carried along, and those symptoms must be very, very well established the way they are as the beginning of diagnosis. But the symptoms are not enough to establish diagnosis. That is why we said here in this slide that to establish a diagnosis of asthma, it should be determined that episodic symptoms of airflow obstruction or airway hyperresponsiveness are present. Those symptoms we have mentioned in the last slide, which is the cough, the tightening, chest tightening, and the rest of them, you must establish that all those symptoms are present. And the way they are present, whether they are was the way they are presented in the last slide, how I mean, whether they are present in early morning or they are present at night. And of course, you must have at least more than one of the symptoms we present. That is the only way to establish that. And of course, airflow obstruction is at least partially reversible. With this airflow obstruction, the only way you can know whether it is partially reversible is when you conduct what we call pulmonary function test. And of course, this pulmonary function test is the most important gold standard in establishing asthma in patient. And of course, not only in establishing the diagnosis, the pulmonary function test is also very important in therapy monitoring. If there is asthma, alternative diagnosis must be excluded, meaning all other disease conditions that have similarities with asthma must be excluded clinically and evidently before you are able to establish that this is an asthma patient. And I assure you, these processes of identifying all the symptoms coming to the point of diagnosis, the patient must be carried along. Next slide. So the pulmonary function test, just like I explained, I told you is the gold standard for establishing the treatment, for establishing the diagnosis of asthma. And I said it is also another gold standard for monitoring of therapy. So it is very important as pharmacists to understand the entire process of diagnosis right from the time patient comes into the hospital, such that we can now have the ability to make appropriate therapeutic recommendations. Because one of the problems, according to standard, we realize that has been realized is that one of the reasons for therapeutic failure is even incorrect diagnosis. So for you to be able to know these drugs are correct or these drugs have been given at the optimum level to a particular patient, you must be able, even if you are to evaluate the patient comes into the hospital to the time the patient has been established to have asthmatic attack. When these things happen, it means you can now use the parameters available, the laboratory tests, the clinical presentation, subjective data, objective data, and all other things. You can put all of them together to identify the rationale behind every single drug the patient is given. This pulmonary function test, this is based on expiratory volume, and we have forced vital capacity. And the process of establishing this, there are very simple procedures which they use in the hospital in diagnosis, and at the same time you can use in your community pharmacy. The patient can also have it handy, because there are simple devices known as a simple device known as spirometer, or you talk about forced vital capacity. Volume is the air expired in the first second during maximal expiratory efforts. And the forced vital capacity is the total volume of air expired after full inspiration. These are meant to identify at least two things. The two things are either there is an obstruction. When there is inflammation, there is edema, there is vasoconstriction, all within the airways. By the time you go to do spirometry, there is tendency to have, because this spirometer, they are all calibrated, and there are different types. There are even digital ones that you can just look at it and take the reading. And there are also reference values. And apart from the reference values, there are also baseline data. When you take spirometer reading, time you also come and take it. You compare between the baseline and the latest value to see the difference. So what we are saying here is that when the first expiratory volume and the first vital capacity, they are there. The more you see the values of the FEV or FVC going down, the more there are chances for the presence of obstruction or presence of restriction in the airflow. And of course, the next is to take a ratio. There's also taking the ratio of the FEV and FVC. So the more the ratio of FEV and FVC reduces, the more it shows that there is an obstruction or there is a restriction of airflow. And spirometry is the fact that to differentiate spirometry tests in asthmatic patient and other diseases like chronic COPD is that when you take the baseline data of FEV and FVC and you administer a short-acting beta agonist, which is fast acting, after some minutes or after a while, you now take another reading. You compare the two. By the time you see a little bit improvement after administration of that, that confirms the diagnosis of asthma. And it is the same procedure you use when the patient is on particular drugs to be able to control deterioration of lungs function. Because the more there is poor treatment of asthma, the more the lungs continue to deteriorate. And when the lungs continue to deteriorate to the point of having airway remodeling, airway hyperplasia, or airway atrophy, then the more it becomes very, very difficult to control exacerbations or to control attacks. So when you look at all these things, they are very important for diagnosis and they are very important for monitoring of therapy. Peak flow measurements are also just like the spirometer measurement. Next slide. This is just a simple example of some of the spirometer. Next slide. So, next slide. So, the next slide tries to talk about the goals of long-term management. Ordinarily, the short-term goals of managing asthma patient is rescue. asthma has to do with breathlessness. And anytime there is breathlessness, it means there's tendency for something unforeseen to happen. So automatically, we're not even talking about the short-term goals, but the long-term is to achieve and maintain control. Achieving control is tied to correct diagnosis, just like I explained. Maintaining the control also is tied to the appropriate classification of the asthma condition based on the 4 classes of severity. So by the time you are able to do that, you'll be able to have a very good control of symptoms. Maintain normal activity, because most patients that have asthma have difficulty undertaking a lot of the activities. They are limited, especially exercise and other activities that require some strenuous things like that. Maintain pulmonary function as close to normal levels as possible. Just like I said earlier, the more the asthma is well controlled, the more the pulmonary function is preserved. Preserving the pulmonary function is very important for continuous management of the patient and for the patient to continue to have proper control. And of course, preventing asthma exacerbations. And of course, more importantly, when you give patients several drugs, one of the very good thing about especially glucocorticosteroids is adverse drug reactions, because you can see as we move into the treatments, there is tendency to step up treatment and there's tendency to step down treatment. And in most cases, there are drugs that have great adverse drug reactions, adverse effects, that the more you upgrade, the more you step them up, the more the likelihood of developing a lot of exacerbations, adverse drug reactions. So trying to make choice that is going to be effective in controlling asthma exacerbations and at the same time having less side effects is also another goal. And of course, more importantly, to prevent asthma mortality. Next slide. These are some of the drugs. Next slide. The drugs are generally classified into 2, even though in some quarters, like one of the resources I've used in making this global initiative for asthma, they try to classify the drugs into 3 classes. But for the purpose of this class, I try to classify them into 2 classes. Whether you have controller medications or reliever medications. Controller medications are used in the maintenance of therapy, while reliever medications are called rescue medications. When there is exacerbation or there is attack, you give reliever medications. One of the very good reliever medications you give is short-acting inhaled beta agonist, which has rapid action. And when you give it inhaled, it goes directly into the lungs and it acts to open up the airways, and the patient gets and the patient's asthma immediately exacerbation stops. So these are some of the drugs: the inhaled glucocorticoids as controller medications, leukotriene modifiers, long-acting inhaled beta agonists, and inhaled glucocorticoids. You can see we are combining long-acting inhaled beta-2 agonists with inhaled glucocorticoids, because in most of the guidelines and in most of the clinical researches, it has been shown that long-acting inhaled beta-2 agonist alone is not very good for control or for prevention of exacerbation until when they are joined together. And of course, you talk about systemic corticosteroids, especially oral steroids, and we have the methylxanthines, we have the chromons, we have the anti-immunoglobulin E. These are all implicated in the pathogenesis of asthma. And these drugs have come about as a result of years of research and years of treatment, years of clinical trials trying to block some of these elements in order to identify whether they are in. No research that can tell you exactly how anti-immunoglobulin, the leukotrienes, and all those elements, especially anti-immune elements, no research can show you exactly how they interact to cause asthmatic attack. But clinical researches have shown that when those drugs that block their secretion are used, there is usually improvement in exacerbation. There is usually improvement in asthmatic attack. So these drugs have been proven to be of great efficacy, but the most important and most efficacious drugs in the control of asthma are the inhaled glucocorticoids and long-acting inhaled beta-2 agonists, usually used in combination. Next slide. So just like I said, the rapid-acting inhaled is the most important reliever medication. And we have, of course, you have the systemic glucocorticoids, you have the anticholinergics, you have also the methylxanthines, and of course, these are majorly the drugs that are being used for the immediate relief of this patient. Of course, some of the drugs, both in the reliever and in the controller, are categorized in other claims as additives. There are drugs that are also what I mean is that there are drugs that are categorized as additives. The first line therapy in trying to maintain therapy is the controller medication. When there is an attack, you use reliever medication. One thing that is very important about these two classes of drugs is that one of the things that is very important as pharmacists to identify in patients having asthmatic attack is to see whether there is control of symptoms, whether the asthma is either well controlled, whether it is not controlled, or it is poorly controlled. One of the indications concerning the drugs is the more the patient uses reliever medication, it is indicated that this particular well organized. The more it is used, the more it shows that there is failure of treatment. When you have less use of reliever medication, then it is an indicator of good control of asthmatic attack. More use of reliever medication, such as short-acting inhaled beta agonists, is a way of showing lack of success in the treatment, meaning there is need to check certain parameters to know whether something is wrong along the line. And of course, just like I said, this treatment can either be stepped up or be stepped down, just for the purpose of achieving control. And just like I said, it is either well controlled, not well controlled, or very poorly controlled. These are some of the points, specific points of patient education, basic facts about asthma. Now you can agree with me right from the beginning of this. I told you every single thing about diagnosis, evaluation of the patients, going into the final established diagnosis, the patient should know. That is what we mean by basic facts about asthma. Every single step regarding the establishment of asthma, institution of treatment, and continuous monitoring must be completely exposed to the patient. Well defined, what defines well-controlled asthma and the patient's current level of control. Anytime the patient comes with exacerbation, there is always likelihood of asking the patient, how many times do you have this attack in a month, in a week? How many times does it wake you in the evening, in the night, as per coughing and other kind of symptoms we have mentioned earlier? These are processes and these are parameters, these are tools we use in trying to control, to identify whether the asthma is well controlled or not controlled, and the patient must be brought together. You must bring the patient up to speed to understand this is what defines the well controlled or not well controlled. Roles of medication and need for adherence. This is very important for the patient to understand that this particular drug I'm inhaling, this particular drug I am taking in addition to inhaler is responsible for this and this. And the moment I refuse to take my medication as prescribed or as explained by the pharmacist, the more I begin to have the symptoms of lack of control. Of course, you must also teach the patient skills on how to use spirometer, skills on how to use peak flow meter, skills more importantly on how to use inhalers. A lot of patients have therapeutic failure as a result of inability to use inhaler correctly. And of course, there must be self-monitoring. What I'm talking about in all this is that when you look at it, for patient to be able to have all this information about basic facts, about what defines control and not control, what are the rules of medication, what do you mean by adherence, inhaler techniques, the patient must be carried along from the beginning to the end. And when the patient is not carried along, you can just finish all your vernacular. At the end of at the end of the day, patients have something. They know they have disease condition, and when they come to look for solution, they are just looking for solution immediately. Once there is no solution, the patient tends to go back to another area looking for solution. If it is hospital, they move from one hospital to another. When there is no proper inquiries, patient come down with multiple and duplicated prescriptions from different doctors. And the same thing in community pharmacy and other places where patient visits to seek for solution to their problems. So when patients are not very much aware about this, they tend to lose confidence. They tend to continue to look for solutions elsewhere, while the solution is right in their pocket. When and how to handle symptoms, when and where environmental exposure. Next slide. Encourage patients by choosing a treatment regimen that achieves outcome and addresses preference that are important to the patient or caregiver. It is very important, just like I told you, if the patient is not carried along, at the end of the day, what you are imposing to the patient is your own decision. There are certain things that have options. When you give the patient option, the patient will choose. There are areas where the patient will not have option. It only requires that you explain to the patient why the choice of a particular treatment, especially inhaler techniques. We have different types of inhalers, and those inhalers have different ways of use. Certain patients prefer certain inhalers to other inhalers. So in choosing appropriate inhaler, always bring the patient in and always discuss with the patient, show the patient how to go about the inhalers, and the choice of which inhaler to choose should be accepted by the patient, which is going to play a very important role in making the patient develop confidence and continuously use the inhaler. Reviewing the success of the treatment plan with the patient caregiver at each visit. And that is the basis where the issue of stepwise approach comes in. That is where the issue of stepping up treatment and stepping down treatment comes in. When there is success, for example, in when you look at the different categories of asthma, from the intermittent to the severe, what you have is different categories of asthma have been tied to certain classes of drugs. When it is intermittent, for example, there is always no need for daily inhaled corticosteroids. Corticosteroids, just like I told you, is one of the drugs we use for the prevention. When it is not enough, or when the level of asthma is not being controlled, it is always and usually being combined with long acting beta agonists. These are the two major drugs, and the way to combine them by looking at the hierarchy of the asthma classification in terms of severity is that sometimes you use only the inhaled corticosteroids. When it doesn't work, you use long acting beta agonist inhaler together. When it does not work, you increase the dose of inhaled corticosteroids to the moderate dose. When it does not work, you also increase the dose of that inhaler, that is the inhaled corticosteroids. So by the time you achieve control, and you are using a very high dose of inhaled corticosteroids, after two to after 1 to 3 months, there is need to start stepping down the use of inhaled corticosteroids. We know the side effects of steroids, and you know you cannot take steroids for a very long time because of the enormous side effects they have. So you now begin to step down the treatment, considering every factor, considering every single factor that probably could have been responsible, and closely monitoring the outcome. Because when you step down and the exacerbation shoots up, then it means there is a problem. There are manipulations. When you use the level of inhaled corticosteroid, long acting beta agonist, of course, when they are not forthcoming, there is also chance for adding methylxanthines. There's also chance for adding uh, immunoglobulin antagonist. There's also chance for adding leukotriene inhibitors, the Zyprelucas and the rest of them. All these things are controller medications. And according to how I mentioned them, inhaled corticosteroids, long-acting beta-2 agonists, methylxanthines, uh, uh, leukotriene inhibitors. That is how they are arranged, and that is how they are supposed to be followed, because clinical researches have shown that none of the none of the leukotriene inhibitors, immunoglobulin antagonists, and other classes are as effective as inhaled corticosteroids in the control of asthma. So when especially you have cases of severe exacerbation, and that is the fourth class, the use of inhaled corticosteroids, you have no option than to use it, and at a very high dose. And the purpose is to achieve control. When control is achieved, then you begin to manipulate, go down, add the additives, continue monitoring, recording the success, checking spirometer, understanding that there's always improvement in the airflow, there's no obstruction, all those things. And of course, tailor the asthma self-management teaching approach to the need of each patient. Maintain sensitivity to cultural beliefs and ethno practices. So these are very, very important in terms of specific patient education. And when you look at those specific patient education, like I told you, by the time you get to specific patient education and the patient has not been carried along right from the beginning of diagnosis to the point of choosing therapy to monitoring therapy, there is no way those points could be incorporated into the patient, and for the patient to develop confidence, and for the asthma exacerbation or asthma attack to be well controlled. And very important, we must remember diagnosis is very important, because it is not only the drugs that you need to mitigate here. Basically, it has been proven that most of the reasons for therapeutic failure are either incorrect use of inhaler, there is also poor adherence, there is, more importantly, exposure to triggers. There are certain cases where you have comorbidities that also exacerbate asthma. There is also issue of incorrect diagnosis. That is why I emphasized earlier on that diagnosis is very important, and that diagnosis cannot be based on symptoms. The fact that you have coughing, wheezing, chest tightness, and you have either two or three or even all of them, does not imply that you have asthma. There must be proper evaluation, and one of the gold standard is the use of spirometer. This spirometer will show whether there is obstruction or there is no obstruction. And in fact, one of the ways to differentiate between asthma and COPD, I told you, is when you take the reading of spirometer in the first instance, and you, after taking the first reading at baseline, you administer inhaled short acting inhaled beta agonist, and you take another reading and there's improvement compared to the baseline. This shows you that this is not COPD, this is asthma. And of course, during treatment, in a lot of cases, you find out that some patients are placed on asthma treatment when they do not have asthma, because initially there was no proper establishment of the asthmatic condition by not following the proper channels. So automatically those things will affect the entire process of drug choice and at the same time monitoring of therapy. And when those things are affected, you continue to manipulate the drugs, you continue to increase the dose, you continue to step up, to step down, increase number, and there will be no. So therefore, this diagnosis is very important when it must be established. And of course, just like I said, incorrect use of inhalers. A lot of patients don't know how to use our inhalers. And this is where the pharmacists play a very key role, because use of inhalers, we have different types of inhalers. And in these days, we even have a lot of other pharmaceutical companies producing different types of inhalers. All you need to do as a pharmacist is just to look at the manufacturer's specification and the manufacturer's instruction. With the basic foundation you have on how to make use of the previous inhalers, you can easily read and understand how to use no matter the type of inhaler that has been produced by any pharmaceutical company, because sometimes the medical sales rep visit and explain the method of use of all the inhalers. So the next slide you can see just gives us a little bit of different types of inhalers we have. It is either metered dose inhalers, which we are very much familiar with, a lot of us, the large volume spacer and dry powder inhalers and nebulizers. And these are different types of nebulizers, different types of devices used as inhalers. And of course, the choice of which of the inhaler depends on so many things: the age of the patient, the severity of the disease condition that at the end of the diagnosis. Because at the end of the diagnosis, you must be able to classify the patient into one of those classes. And if the patient is classified into one of those classes, as regarding the four classes we've mentioned, it means the treatment must tally with the class of the severity. So in that case, the choice of inhaler will also depend on that. And of course, so many other factors are responsible for are being put into consideration. And more importantly, like I said, patient's preference. When the patient does not like a particular thing, it is either you use a particular way to convince the patient that it is the best way, or you have to go with what the patient likes, as long as it will not interfere with the process. You can see one of these devices is nebulizer. These days, we are beginning to have simple nebulizers that can even be kept at home. Not to even talk of our community pharmacy outlets where you can use nebulizers for patients, especially for patients that have severe attack. Patients that have severe attack ordinarily are supposed to be given first aid while on your way to the hospital. So sometimes you can have patient that is severely attacked and will probably cannot reach hospital without certain assistance. And of course, the use of nebulizer, you can place the nebulizer and continue to rush the patient to the hospital, and so many other techniques can be used in that. And the next slide, you can see, just to give you some of the factors that actually affect the choice of inhalers, either the drug required, age, severity of the disease, and patient preference. I think I've explained these slides in the last slide. And the next slide, just by way of trying to give us a sense of how patient and a lot of healthcare professionals do not understand how to use inhaler. That is why I brought this slide, which is supposed to be probably the end of my this is going to be probably the last slide in my presentation, just to show you how difficult it is for a patient to be able to follow this step uh, according to how it is placed. I think it is not out of place if all of us as pharmacists look at these steps one by one and remember how we gave the last patient that came to our place, or how we explained to the patient how this particular steps were followed, according to how removing the cap. When you look at it, how you remove the cap, hold it upright. Holding it upright and shaking this vigorously will distribute the drug. Breathe out gently. This is another step that we normally don't take cognizance of. Before the inhaler gets to the mouth, make sure the patient breathes out all the air, almost most of the air, out gently, not necessarily stressing the patient. Then the next thing, close the mouth around the inhaler completely. Some patient will place the inhaler in the mouth and at the same time allow certain openings, such that when they are taking in the drug by pressing the canister, a lot of the drugs are going out through the opening. So look at it. After gently breathing out, placing the inhaler into the mouth and closing all opening, then the next, breathe in slowly and deeply through the mouth. Here, some patients breathe in only inside the mouth. When you are breathing and at the same time, these 5 and 6, they always go simultaneously. While you are breathing in slowly and deeply, you are pressing the canister at the same time, not breathing to allow the drug inside your mouth. Rather, you are breathing inside your lung through the mouth, just like you breathe in through the nose, through the nostrils. You don't give chance for any air that you breathe through the nose to stop at the neck or to stop inside the nose, just like as we do. We can breathe in air, something like, and stop the air in our mouth. We don't do that when we are breathing, when you are using an inhaler. We rather take in the air directly into our lungs. That way, it gets down into the lung. I said 5 and 6 go together. While you are breathing in, remember the mouth is tightly closed, making sure that all openings have been closed. Pressing the canister and breathing and taking in slowly and gently is the next step. Then the next thing is hold your breath for at least 10 seconds, meaning remove the inhaler, close your mouth and hold the breath for like 10 seconds. Then breathe out through the nose. Remember, before you inhale, you must close your nose around the mouth. Close your mouth around the inhaler. When you are breathing in and your nose are open, it means you are breathing both the drug and the air, and they are mixing together to become diluted so that the maximum dose will not reach the lungs. Breathing gently while the nose, you don't have to use the hand to close the, rather you close the nose from inside. Close the mouth around the inhaler. Press the canister and breathe in slowly and gently. Stop, close, hold for 10 seconds, then breathe out through the nose gently. And if a second dose is required, then you do that after 1 minute. And that solves the problem. And I assure you, this simple procedure leads to a lot of asthmatic patients getting injected by either aminophylline IV or hydrocortisone IV. Because by the time you keep using this inappropriately and the dose is not getting to the lungs, that way you continue to have your attack because there is no way. So the next alternative is probably, especially in some of the clinics, you go ahead and start administering IV drugs, which probably wouldn't have been necessary. So generally what I'm saying, you can, when you look at it very clearly, there is disconnect. A lot of pharmacists believe that you don't need diagnosis. They don't need to be part of the process of evaluating patients. They don't need to be part of the process of our understanding how diagnosis is made, even if they are not around. That is why a lot of pharmacists cannot even open a patient folder, understand what has happened within the folder, and be able to extract information and arrive at conclusion. And I assure you, as long as you cannot have all this information yourself, open the patient folder, even if you're not there, certain things that are not in the folder, go to the patient, go to the nurses, ask the physician, put all together. Forget about doing anything pharmaceutical care, because this is real pharmaceutical care, and pharmaceutical care requires that you do assessment. And for you to be able to do assessment, you need to put all information together. There is no way, just like we have seen in our presentation of drug information. I think we have had a series of drug information presentation. One of the things that I got interest with when the presenter was telling us that when an information comes to a drug information unit, you must know where that information is coming from. If not, if you give an answer, it might be a wrong answer. You must know the purpose for that information. You must know what that information is going to be used for. If you do not know, at the end of the day, whatever information you give could be very wrong. And at the end of the day, anybody getting information from you will lose confidence in you. And this is something in pharmaceutical care practice. When you just think you can just look at prescription, look at dose of prescription, look at combination, and just begin to challenge prescription. A lot of times you are going to have a lot of beatings, not necessarily physical beating, but some of those physicians that know exactly what they're doing are going to put you to shame. So that is why you must understand every point, and you must understand every assessment. You must understand every lab investigation. You must understand every process that has been done to arrive at a conclusion. And all these things, when you be discussed with the patient, with the understanding of the process the patient has gone into, you should be able to convince the patient and take the patient along, so that the collaboration is not only with clinicians or nurses, but the collaboration is also with the patient, such that the patient will have confidence and the treatment will be optimized, bringing down adverse effect, improving efficacy, and improving patients' quality of life. This, I believe, are some of the things I have put together. There are a lot of things to talk about diagnosis. There are a lot of things to talk about in drug treatment. There are a lot of things to talk about in patient education. I just decided to pick up a few things, especially that I believe it is going to be an interactive session, and a lot of people will have more information than I have. A lot of people will have a lot of things to put and make the presentation much more better, and so many things. So the last slide is just to present the last slide. And the last slide is just to tell you some of the sources of information for further readings and getting more information. Global Initiative for Asthma, the updated version, updated 2018. And of course, there's also British Guideline on Management of Asthma 2011. And of course, we have the Applied Therapeutics by the popular Koda Kimball. Some of the information are gotten from these sources. For further readings and further information getting, I think we can check all these sources. Thank you very much. Thank you very much. I think, Dr. Bello, you can go ahead.
I call on Dr. Williams to take over the motion for you. Dr. Williams,
this is
permitted to omit yourself. Dr. Williams,
I'm yes,
continue the
okay.
Please continue, please.
I sincerely I want to thank Dr. Usman for this detailed presentation. I think he deserves a round of applause. This is very detailed and educative, and I admire the passion with which he unpacked the diagnosis and the management of asthma. Dr. Usman, thank you for a great work. I think the floor is open now for question. I'm seeing Dr. Joseph Mandu's hand raised. Dr. Joseph Mandu, you can go ahead with your question. Dr. Joseph Mandu.
Yeah. Okay. Thank you. I can see that I was muted. Good evening, everyone. I
Good evening.
Yes, I don't want to even say it. I want to really congratulate Nuruddeen Usman all the way from Sokoto. I'm so happy. Actually, when we posted his presentation on received the highest likes so far since we Usman. The first day I posted it, I was receiving about 100 likes. I said, wow. And later I saw people making comments. Someone said he's one of the best lecturers they have in his university. And he has proven every element of that thing that was ascribed to him. I hope you can hear me.
Yes, yes.
Everyone that is here, and all agree with me. Those who were not at this night today's presentation, they have really missed a lot. We are going clinically with me that if we continue this, Nigeria will be in the Guinness Book of Records among the first best pharmacists. Didn't think about it this way initially, but today we see that every week we are learning, all of us are learning. Our bank of knowledge is increasing. This man, you can see him talking about the water, and I know God made it pharmaceutical care. In pharmaceutical care, in talking about drug therapy problems and untreated indications. And that is why I laugh at pharmacists who said that pharmacists are not trained to diagnose. Foul. If they are giving the wrong drug, the patient is given the wrong drug. The patient is being given an drug. The patient is being given a drug. The patient doesn't have asthma because you have used your the pharmacist Nuruddeen and you use your spirometer and discover that this patient doesn't have asthma. This patient probably has COPD. And what do? You classify it under drug people as treated. And yes, and patient also of what you're bringing to the table. And family profession will pay for it. For people will not say we are just counting drugs or carrying cartons and we want to be called consultants. People we know is even the physicians and the rest that will even be fighting for us. But for now, we have not been bringing a lot to the table because we have not really positioned the profession. I can see what God has brought to us through CPAN, leading us to be the healthcare team, and it will be best for Nigerian patients. Once again, pharmacist man, congratulations for doing a
Thank you very much.
and please, I plead with you to help CPAN to another level in Sokoto State. God bless you.
Very much.
Thank you.
Thank you.
Okay. Thank you very much, Dr. Mandu, for your contribution. Can we hear from Dr. Ejiro? Dr. Ejiro, you have the floor now.
Okay, thank you very much. I want to especially thank the presenter, Dr. Nuruddeen, for a wonderful, exhaustive, and simplified presentation on asthma. In fact, like he mentioned, a lot of the times COPD have been mistaken for asthma, and patients have been treated for asthma when they had COPD. And pharmacists truly need to up their game with regards to patients who have been managed for asthma, and especially
Hello, Dr. Ejiro.
patient counseling with the use of proper. So mine is not really a question. Can you hear me?
We can
Go ahead.
Hello?
Now.
Hello?
Yeah, go ahead.
Go ahead now, Dr. Ejiro.
Okay. So, like I said, he thoroughly dealt with the topic, and I believe when this material is shared to those who are not here and those of us who are here, it's a great opportunity to, especially for those with asthma. One of the distinguishing features for COPD and asthma, especially in children under 5, is the fact that for asthma, when you auscultate, you always will have bilateral wheezing, while for COPD, it is unilateral. So that is another classical way able to differentiate if a patient is having COPD or having asthma, especially for under 5s. Thank you very much.
Thank you very much.
Thank you, Dr. Ejiro. Please, if you have a question, you can raise your hand. Can I call on Pharmacist MM? Pharmacist MM, you have the floor for your contribution or question.
Yeah, thank you very much. Good evening, professional colleagues. CPAN, I want to start on the existing protocol. Thank you very much, Dr. Usman, for that wonderful presentation. Well, I have a few questions I want to ask. Asthma has been a very interesting topic to me. I've worked on in the past, and I'm still working on. But there are some few things I really want us to look at as pharmacists. How many pharmacies have spirometers and peak flow meters? Those are the first question we ask ourselves. And then the few peak flow meters we have, how do we use it? You know, because like, it was a very tight situation, especially in the era of COVID. How do you intend? Because how many patients want to subject themselves to using the peak flow meter in the pharmacies? So these are the questions I want us to look at, because it's quite great. I mean, we know about the drugs, we know about everything. Then nebulizers too. How many pharmacies take our time to counsel patients on how to use nebulizers? I also ask question too, how many pharmacies also take our time to counsel patients on the use of the meter dose inhalers or the ACU inhalers? I will tell you the truth that we've not done enough in this regard. The doctors prescribe, I'm talking about the physicians prescribe products for patients. They expect the pharmacist to counsel the patient at the point of dispensing of the product. I don't think up to 5% of the patients get the proper counseling. And that's where the problem comes from. So you now have a case of unmet needs where the drugs are not being administered properly. So if the drug is not being administered properly, to start with inhalant, what percentage of the product eventually get to the lungs for it to act? So that's where the problem really comes from. And the patient on their own part are usually very, very impatient when they come to dealing with us pharmacists. They see us as the last people they want to see in the small cubicle before getting out from the hospital. The patient that have been in the hospital that have really remained a patient all the while, mainly gets a prescription from the doctor, becomes very impatient, becomes irritated, wants to get out of the hospital on time. So how can pharmacists now add value to enable the patient listen to our counseling? Those are the questions I want us to please discuss. Thank you very much, sir.
Thank you very much, Pharmacist MM. Please, I want to call on the presenter, Dr. Usman. Please attend to the questions, please.
Okay, thank you very much, Pharmacist MM. I think the questions are rather not directly questions for answer, but it is a kind of thing they are kind of questions he has thrown as challenge to all of us pharmacists. How many pharmacies have spirometer? One of the things we must understand is that we have, as he rightly mentioned, a lot of pharmacists believe they don't even need to be part of diagnostic process. And when you have pharmacists who have this kind of mentality, automatically they believe spirometer is not even for monitoring of therapy, because only very few pharmacists understand that it is not only for diagnosis. That is why in my presentation, I try to emphasize that spirometer is both for diagnosis. In fact, it is the gold standard simple device that is being used to establish diagnosis. Without spirometer, there is no way diagnosis could be established, especially that we know there are certain disease conditions that also mimic symptoms of asthma. So pharmacists who do not believe those things, they are supposed to be part of diagnostic process. They don't even want to get. If not, it doesn't cost anything to have a spirometer. We are not even talking about only pharmacies having spirometer or having spirometer in their community pharmacy or in their own house for normal use. But it is important for the pharmacists to even encourage the patients to have a personal spirometer and to be able to develop skills which the pharmacist will teach the patient to be able to monitor his own lung function, because monitoring that lung function is very, very important in achieving success in treatment. So the truth of the matter is, this is just a matter of perception. And it is only when pharmacists begin to realize that clinical pharmacy is all encompassing, and that is when everybody is now going to embrace every single part of treatment. That is why I said from the beginning that the collaboration we are talking about is not only even collaboration with only healthcare professionals. It means there is no option as to collaborating with healthcare workers. You must be part of the healthcare management team. And for you to be part of healthcare management team, you must be able to understand the language they speak. You must be able to understand every single thing they do. If you do not understand every single thing you do, tell me what you are going to do in a ward. If you stand in the ward, they are using spirometer on a patient and they are recommending treatment. Tell me, even if you don't have it at home, tell me how you are going to be able to make recommendation of either stepping up treatment, changing treatment, or stepping down treatment. It is not possible. So what we are saying is that we must understand the value in going in and understand every single step. That is where the doctors have gone ahead of us. Go and see, even where they are not supposed to be, they have all joined and they claim to be experts. That is why everything you bring up, they have an expert. When you go to blood, they will tell you they have hematologists. You go to anesthesia, they say they have anesthesiologists. When you go to, in fact, even this thing they call photographers, radiology, they say they have, and they monopolize everywhere. Why? Because they try to be part and parcel of that. So these are the things we must put aside and encourage our people, and also change our attitude to understand that this thing is not going to be done like that. Just like we have had, how can you become a consultant in cardiology or in pulmonology or in endocrinology or in any of the units of internal medicine without understanding what they are doing, without understanding the simple devices they use at bedside to identify how to administer or how to prescribe? It is not possible. So it is a kind of challenge, not necessarily a question. Everybody must have it. Everybody must learn how to use it. Everybody must also learn how to teach the patient self-management skills because I made mention of three things. The skills for the use of inhalers. Self-management skills is all encompassing. Even how to avoid triggers. Even how to avoid triggers is part of the skills. Patient must be able to identify those triggers that cause exacerbation in his own asthma, because it is not all the triggers that will act on all the patients. The fact that we have a number of triggers, tens and 20s of them, does not mean every patient will react to all of them, but particular patient will have certain triggers specific to him. So it's just an all-encompassing. That's just what we are seeing. Thank you very much.